So I've been asked to speak about the dietary management of gastrointestinal conditions. I've picked up a few of the key ones that I see, but if there's anything else you want to ask about, just fire away, because there's all manner of things that can go wrong with the GI tract. So, I'm Sarah Elliott. I'm a dietitian. I work in private practice in Wellington. We have a team of dietitians, one of who has celiac disease. So she sees everyone with celiac disease. I have inflammatory bowel disease. I have Crohn's, so I tend to see a lot of that. And then we have a selection of dietitians who specialise in gastro as well. So we do a lot of digestive conditions, as well as having a paediatric dietitian too. So I'm going to mainly be covering irritable bowel syndrome, diverticular disease, just a slide on that, inflammatory bowel disease, and then celiac disease. I don't think we'll be overlapping too much, but there might be a little bit of overlay. So as we know, irritable bowel syndrome is really common. You probably see it almost daily in your practice. I certainly do. Lots of different symptoms, predominantly to do with the digestive tract, but we also see things like fatigue and back pain due to the bloating, the pushing on the lower back. Whether we have alternating bowels or we have diarrhea or constipation is often to do with which bacteria is present. So methane bacteria often constipating, hydrogen often have looseness and diarrhea. So sometimes people can be having the same foods but be triggered in different ways because of the types of bacteria that we've got presenting. The brain fog is a very generic symptom that a lot of people present with, that cotton wool feeling in their head, and that can be something that's either from the gluten or from just a general bowel irritation as well. So in our practice, we always ask for a celiac screen if anybody presents with any type of symptom, and that's really tricky, as you all know, if somebody has been to see a naturopath or a homeopath or spoken to their friend or their neighbour or Googled and are already on a strict gluten-free diet. And it's really unfortunate because what that means is then you have to try and convince them, as you know, to try and go back onto gluten. And if they do really have a gluten or a FODMAP problem, it's a very uncomfortable experience for them, because as we've talked about already, there tends to be this exacerbation of symptoms more so than they would have felt in the first instance. But we've talked about how to combat that, so that's something we always get asked. We're always looking for red flags, just making sure people have seen their GP to make sure nothing else, everything else has been looked at. And we often see people who present with IBS and other conditions at the same time. So I've just listed a few there, but fibromyalgia, anxiety, mental health, celiac, inflammatory bowel disease, all those types of things that can quite commonly present at the same time as someone with an irritable bowel. So it's understanding how much of those conditions are driving the symptoms versus something that we could be looking at from a dietary perspective. So if you think about 15, 20 years ago when I was first studying, the general advice we were given for irritable bowel syndrome was make sure you're drinking enough, make sure you're eating all bran, enough fibre, and make sure you get plenty of exercise. So and avoid windy things like cabbage and things like that. So that tended to be our main arsenal of advice for people with IBS, and understandably it wasn't that successful in a lot of people. By the time people come and see us, I'm not sure about yourselves, but they've usually tried this. They've usually tried to up their fibre, they're usually trying to drink enough water, particularly if they're constipated, and usually exercise is something they've considered, but not always everyone's doing it with desk jobs and the like. But exercise, fluid and fibre are still mainstays of things that we check. We still check to see if people are drinking enough fluids, if they're constipated, still checking they're getting the right mixture of fibres, which I'll be talking about a little bit later on, and making sure that they're getting movement to help the colonic and digestive system working. And also obviously there's a stress management component of that, and we know that stress and bowels have a very strong relationship there. So we will always go through common triggers with people. So a number of people in the room, including myself, will notice that these things upset people. So the spicy food in terms of the chili, capsaicin, which is found in capsicum and chilies, has a particularly strong reflux and bowel problem issue. We've got rich foods, which is the kind of fatty, greasy, oily type heaviness that people will respond to. too much alcohol, because alcohol in itself is a bowel irritant, and so people will have a threshold as to how much they can have. Some people are okay with a glass, some people can tolerate 2, some people can't even have half a glass, so that's a very individual tolerance. Caffeine, again, is a bowel stimulant. Some people rely upon it to actually go in the morning, and then other people will notice that they might go a bit too urgently if they have it, so they need to cut to decaf or things like that, and ride through the headaches at the other end of coming off. And then fibre. So fibre is really interesting. It's in the dietetic world, it's becoming quite a hot topic, because we're realising the different types of fibre and how they work together, how they assist each other, and how they feed our bacteria in different ways. So it used to be quite a generic, just try and get more cereal fibres and more fruit into your diet, but now we're looking at things in a little bit more detail. So when we look at somebody's food diary, we will actually pick out what types of fibres they're having and where we might need to change things depending on which types of symptoms they're having. So then we've also got things like eating too fast. So research studies will show that if you chew more, you will get a 20% improvement in digestion. So that's actually, it sounds like such a simple recommendation, but if you can actually get somebody to turn the TV off and actually listen to what they're eating and chew properly, you can actually get better amylase engagement in the mouth, and therefore much easier digestion going on in the gut. Large portions, so when our gut receives more food than it kind of asks for in one time, we can get a lot of stretching, a lot of discomfort, and that's just another thing where we try to get people to eat more moderate-sized portions. And long gaps between eating. So long gaps between eating obviously feeds into eating too fast because you're starving, and then it also feeds into large portions because you're starving. But there's also something that goes on, and we're not sure of the actual mechanism behind this, but if you are hungry, which we describe as an empty, hollow sensation in your stomach typically, but people have different ways of feeling hungry. If you wait too long, half an hour, and then you do eat, a lot of people will experience bloating and wind and discomfort because they've gone past, the sweet spot or the time where your body has actually asked for food, and it won't actually matter what you eat. And so we often see this in people who have jobs where they eat at different times. So they might not get to eat until 2:00 in the afternoon because they were in court, or they've got rushing around with their kids or things like that. So when people only get symptoms on certain days of the week, and it often correlates with them being busy, this is often something that we'll pick up on. And sometimes people just are taking in a lot of air, and that again relates to the eating too fast, when they eat a lot of gum, loose dentures even, talking while they're eating, things like that, which can create a lot more air to come into their stomach. So that's in terms of the nutrition side, just really briefly, the common things that we would look at. But we have to always recognise that the gut and the brain, the enteric nervous system and the central nervous system, they talk to each other a lot. There's a very strong correlation in some people more than others. And so when the brain is experiencing chemicals around and sending signals down to the stomach of distress or anxiety or panic, then the stomach and the digestive tract will feel the same types of symptoms. So stress is always going to be, and about 70%, 80% of my clients will have a stress involvement with their symptoms. And interestingly, I have people who retire and their IBS goes away, or they'll go on holiday and their symptoms are a lot better. So it's often quite an interesting question about that. I remember one woman said to me that she thinks that cider helps with her symptoms because every time she goes on holiday she drinks lots of cider and her symptoms are way better. And I said, I think it might not be the cider, but shall we try that? Unfortunately it wasn't, but yeah, it wasn't the cider. Then we have hormones, so a lot of women notice around ovulation, menstruation, they will get an increase in their symptoms, and we can't always manage that with nutrition, but if they're at least avoiding things that can irritate them more, we'll just have a lessening in the symptoms around that time. But certainly that's a very, very common one. Even people without IBS might get symptoms a little bit around those times anyway. And then very commonly people with IBS have visceral hypersensitivity, where the nerves around the enteric nervous system are just more, twitchy, more sensitive, and so the brain will perceive these symptoms as being higher than they are. Really important that we don't tell people that means they're making it up. It just means that's how their brain and their gut are perceiving these symptoms. So they're very real to these people. including myself, I have IBS as well. And so what they've done, really interesting studies where they've done inflation balloon studies, and have you come across these? Yeah, where they've inflated small balloons in the rectum and noticed what the response rate is, and people without IBS will just feel like they're a bit of pressure, like they need to pass some wind, and people with IBS will be in a lot of pain, very uncomfortable. So we talk to people in our clinic about how to manage that, because even though we're dietitians, we have to think about the person holistically from all angles. So we will talk to people about what are some strategies that they could use to manage their stress. And a lot of people do come in fast talking, highly anxious, sitting on the edge of their seat, talking about their symptoms, but also how busy their life is, and it's not very useful to tell someone to try changing their diet without addressing why they're so tense as well. So we just would mention to them that there are certain strategies that are really helpful for this. So medical hypnosis is a type of hypnosis which is used to change the way that the brain and the gut talk to each other. So it's a very specialized branch of hypnotherapy, and it's only used by medical professionals. So I can't train in it, but a GP, a specialist, they can train in this. And the research shows that medical hypnotherapy, and interestingly a new study showed yoga, has the same effectiveness in IBS management as the FODMAP diet. So if you're somebody who doesn't want to cut foods out, everyone put their hands up, if it meant that doing yoga on a regular basis or investing in a medical hypnotherapy CD set, because you can buy these online, they're specialised in IBS, it's really worth a go, particularly if the person has nut allergies anyway, or they're vegetarian, or you don't think their mental health would cater to elimination. And we're really careful of that in our clinic actually, is that if we think that we would do more harm with removing foods from a mental health perspective, then we might look at other things like probiotics and peppermint oil capsules, and maybe just switching the type of milk they're having, so making some more gentle suggestions than some people. But sometimes going on the FODMAP diet is adding more foods than some people eat. I don't know if you've come across many people who are on very restrictive diets because they're so scared to eat because of how symptomatic they are, and so sometimes going on the FODMAP diet means actually we're adding more foods back into their diet. So diaphragm breathing, there are apps that help people do that. There's apps for everything. So there's apps that allow you to breathe in and out through your diaphragm as opposed to your chest, and stress management techniques. So we're always looking at whether that's going to be complementary to the dietary advice that we might give. So we as you would be as well, there's always the back of our head looking at what else could this be, what else could this be. We always like it when someone has spoken to their GP about their symptoms, because we know that means that things have been ticked off. But we would look for signs of SIBO, and small intestinal bacterial overgrowth is an area of increasing interest in the dietetic world, and how we would manage that. The bile acid malabsorption, more common than we realise from the research we've seen. The non-celiac gluten sensitivity is certainly something. Probably I don't see that often, to be honest, but it's certainly something that I do see. Food chemical sensitivity. Has anyone come across that term? Do you know what I mean by that? Yeah, have you heard of salicylates and amines and histamine and glutamine and MSG and colorants and things like that? So this is a whole separate group, very different from FODMAPs and gluten, where we're taking out the chemicals that are found in food. It's a much harder diet to do, but people are much more symptomatic. So these people tend to have migraines and hives or urticaria, anxiety, nausea, a lot of nausea, dizziness, bitter taste in their mouth, ringing in their ears. They tend to be very sensitive to smells. They have medical reactions in terms of drugs and things like that, so they tend to be much more symptomatic. So I guess the important thing that you can see from there is that we really need to individualise our advice to people, because everybody is different. So some people we can actually, I can think of one woman I'm seeing at the moment, she's got OCD, and so we have tried making some gentle changes to her eating, but nothing has helped at all, and she's symptomatic all the time, even when she wakes up in the morning, even when she drinks water. So sometimes we have to acknowledge when I have to acknowledge when nutrition's not going to help, and I have to be okay with saying, actually, we're just going to have to manage with, therapy and things like that to help manage your the other side of her mental health. So it's about understanding where we can actually make a difference versus just trying to throw everything at them. Because as dietitians, we want to help. As you all do, we have this feeling of I just want to fix somebody, but it's acknowledging where our boundaries are and our limits are about what can be effective. So before I go on to FODMAPs, everyone's favourite topic, does anyone have any questions about the general things I just mentioned? No? Okay. So has everyone heard of FODMAPs? Yep. Yeah. It's I first learned about it when I was working in Australia about 11, 12 years ago, and I listened to Sue Shepherd talk, who was a pioneer of FODMAPs, and she talked about these little sugars that are found in food that she thinks might be causing problems with some people. And fast forward to today, and it's explosive. Well, that was not intended, but it really has gone all around the world. Most countries in the world will have some kind of FODMAP system in place, and there's online programs you can do, there are blogs you can follow, there are recipe books you can buy, there are apps you can get, multiple apps, Facebook pages. So there is a plethora of information out there, which is excellent, but it also comes with the downside where people are doing it all themselves without the proper guidance, and I'll get onto why that's a problem in a moment. So just to recap, many of you probably know this already, so FODMAPs, the F stands for fermentable, and that's usually what I just get people to remember is fermentable, and the rest of them are different types of carbohydrates, so it's oligosaccharide, disaccharide, monosaccharide, and polyols. So they're different types of sugars that are found, and I'm always quick to emphasize with people it's not cane sugar, it's not table sugar, which is what people think of when we mention the word sugar. So it's the actual natural sugars that are found inside really healthy foods. So people are having to get their head around the fact that, okay, I'm allowed to eat canned fruit in syrup but not in juice. So it's the complete opposite to how people would typically be thinking a dietitian would advise. So there are 5 different FODMAPs, and not everyone reacts to all of them, and this again is where people are getting a bit misled, is that they think that FODMAPs is one category and that they have to avoid all of them. But we have the different categories here. So we have fructose, which is people think of as a fruit sugar, but it's only an issue when there's more fructose than glucose in the food. So for example, an orange has 50-50 fructose glucose, so really well tolerated, whereas an apple has 3 times more fructose to glucose. So we have too much free circulating fructose in that situation. So there are very comprehensive lists. What we use in our practice is the Monash Low FODMAP app, which is continually updated as they test more food. So it's what we really recommend our clients buy. It is about $12, but it does update regularly as soon as they test new food. So it's very reliable, very user-friendly. Then we have lactose, which is the sugar found in milk, and we sometimes have clients who are dairy-free. But then when we start adding things like butter and cream cheese and lactose-free milk, they realise it's not actually the dairy protein that they're reacting to, it's the lactose that they're reacting to, which is very different and opens up a whole world of foods to them. And that's very similar to if you have a gluten sensitivity versus a FODMAP sensitivity, that it's very different and opens up a whole new world of foods to you. So then we have polyols, and the 2 main polyols are mannitol and sorbitol. There's also xylitol and isomalt, but they're the main 2 that are found in food and are naturally occurring in food. So we have things like chewing gum and artificially sweetened mints and Robitussin and Dimetab, and things that have got a sweetness that are artificial will often have polyols in them. People always ask me about things like sugar-free Diet Coke and Sprite Zero, but they use aspartame, they don't use these. It's naturally found in stone fruit, all stone fruit, dried, canned, fresh, and cauliflower, mushrooms, celery, just a variety of delicious healthy foods. And then we have fructans, which is the hardest group to avoid. This is where wheat and rye is found, which is where the confusion comes in if someone goes on a gluten-free diet, feels somewhat better, but not completely better, is that they've actually by default reduced some of the FODMAPs out of their diet. So this is where we have to be careful to have proper diagnosis in this situation. So the wheat and the rye luckily is not actually that strict. You can still have a piece of bread, half a cup of pasta, a couple of ginger nuts. It's not actually that strict, but what is very strict is the onion and garlic. Has anyone ever seen how much onion and garlic is found in our packaged foods, ready-made foods, canned tomatoes? It's everywhere, and this is where people find it very difficult. So it's not, they eventually get around it at home, but if you go out to someone's house or you go out to dinner or you want to grab a quick bite on the way to the movies, it then becomes quite problematic. And luckily with FODMAPs, usually it's about an accumulation, it's a build-up, it's if you have too much, but we do have some people who are so sensitive to onions, they just have to have onion powder on some chips and they'll be in the bathroom for 24 hours. So there is definitely levels of sensitivity, and we've asked Monash, why are people so sensitive to onions when they're having such tiny amounts? And the main answer is just the concentration of how concentrated onions are compared to wheat and rye and all the other foods. And the last one are the galactans, and we all know that these are windy and not, a bit challenging to tolerate. There's even a song about it, isn't there, about baked beans? But hummus as well, and it comes in all different types of things. But you can see there why people who are vegetarian or vegan really struggle with this diet, because you can't have certain types of soy milk, you can't have all the legume group, there are certain nuts you can't have, so it can be quite challenging if you've already got dietary restrictions from another point of view to also then lump this on top. So the research shows, and this is from both Monash and in other places in the world, that we've got a 50 to 75% chance that you'll have significant improvements in your irritable bowel syndrome symptoms. It's not a long-term diet, and this is the issue that we're coming into when people are doing that by themselves. And even occasionally health professionals will say, go and look up the FODMAP diet and have a go, without going, and it's only short-term for 4 weeks. Because we're only supposed to be following the FODMAP diet for a short period of time. I actually tell people that it's a diagnostic tool, so it's a diagnostic stage of the FODMAP diet, and then once we know whether you get improvements or not, we go, great, you've got a FODMAP sensitivity, but which FODMAPs? So we add them back in again one at a time, and then we work out how sensitive you are from there. So that's the big gap that's missing from a lot of people who embark on the FODMAP diet. And unfortunately, and Monash have confirmed this with stool sample studies, is that people who go on the FODMAP diet do get a reduction in gut bacteria diversity. So when it comes to gut bacteria, the main thing that we're looking for is diversity. That is the key marker of a healthy gut microbiome and therefore a healthy person. So it's not actually just trying to get up more lactobacilli or more Rutius or anything like that. It's actually wanting to get the most different types of bacteria there. And because you're not feeding them with the FODMAPs, the diversity really starts to get impacted. So I have had a couple of people who have been on the low FODMAP diet for over a year, and they come and see me because they're sick often, they're getting frequent colds and flus and things like that, and I do wonder whether that's has some kind of impact on it. Right, so when are they indicated? If you see somebody in clinic and you've advised them, look, try and just have a bit more water, maybe add more vegetables into your dinner because they'll just eating chicken and rice for dinner, just trying to get a bit more general advice. If they're not responsive to that, then you might want to look at doing the low FODMAP diet. If someone has inflammatory bowel disease, which is well controlled, the CRP is low, ESR, often gastroenterologists will say that they have a functional gut disorder with their IBD. So it's very common to have IBS and IBD at the same time. And this is completely indicated to try FODMAPs in that case. In fact, there's research coming out at Monash about that too. Celiac disease without resolution on a strict gluten-free diet. We do try lactose for a short time, but if that hasn't helped, we would look at that. That's quite a hard diet to do. a gluten-free, low FODMAP diet, it's not fun. So we really need to support the person with lots of resources about the products in the supermarket they can buy, menu ideas, things like that can really help them to follow that. And with these people, we always say to them, if you want to eat FODMAPs, do it, because it's just going to cause you discomfort. It's the gluten you need to prioritise. So there's always that flexibility when it comes to FODMAPs. So you might meet some people who say, look, I've gone on a gluten-free diet and I feel mostly better, but I'm still getting symptoms. And that's often because, and this is if they're cleared for celiac, often because they have partially reduced the FODMAPs in their diet, but they're still eating onions and apples and asparagus and persimmons and things like that. And when we have people say, oh, when I'm sick and I don't eat much, I feel much better, they've just got less fermentation going on in their gut, so that can sometimes be an indication there as well. So when is it not indicated? So I deal quite a lot with eating disorders, and when they start eating again, you'll get a temporary gut distress due to, well, firstly, the anxiety around eating, but also the fact that the gut is getting used to eating food, having food in the gut again. So we would not try any dietary manipulation in that scenario, because that just naturally resolves with time as the gut gets used to more food again. If there is low body weight, I'm also really cautious about that, because I'm not wanting to lower any types of food, especially any wheat-containing foods, which are really easy to be eating enough. Unless the symptoms are contributing towards it. So if they're getting really bloated and windy and diarrhea and it's stopping them wanting to eat, then we might reduce some of the FODMAPs from their diet just to see if we can get more comfort in the stomach and we can get them eating more again. I've already mentioned this here about the low chemical diet. So the Royal Prince Alfred Hospital have a really clear guidelines around what the diet looks like and when we use it, so that's something that we often do as well. And sometimes, unfortunately, we get people with a low an amine sensitivity and a fructose sensitivity, so we might get two together, and actually that's quite common for us to see an amine or a histamine issue with one of the FODMAPs as well. It's quite a common combination. There is no evidence, and I do have people asking me about this, if they've got inflammatory bowel disease and they're asymptomatic, do I need to go on the FODMAP diet in case it makes me have a flare? Absolutely not. In fact, it's quite the opposite. If you can tolerate FODMAPs, you want to be feeding your gut as well as possible in that scenario. There's a really great YouTube video clip that was designed by Monash University, and it describes really easily and simply how FODMAPs work. It's about a 3-minute video clip, so if you have time in your consultation to show it. So if you go onto YouTube and you just Google FODMAPs Monash, you'll come up with that picture of the gut, and it's a really comprehensive 3-minute video clip about that. But failing the fact that we don't have that, I've just got some really simple slides about how they work. So FODMAPs are small, and so what happens is that they get malabsorbed and have an osmotic effect, which causes the diarrhea with extra water being drawn into the luminal space. And the sugars reach the large intestines where the bacteria ferment it, hence the F, and that creates the wind and the bloating and the discomfort with that. And then some people get particularly a lot of pain or cramping if they've got SIBO, because the small intestines are being expanded, and that's very uncomfortable. And then the nausea can happen with the bloating as well. So this can also contribute to body image issues, where people feel like they're much bigger than they are and they feel very self-conscious about it. So it's something that affects people's quality of life, having IBS. I had a gastroenterologist tell one of my clients that people with IBS live a long and torturous life, and it wasn't the greatest message for them to hear, because they really wanted to know that there was something they could do to manage their symptoms themselves. So she had a laugh about it and said, great, I feel like I can actually do something about it now. So it's all of this discomfort, this pain, and this bloating, and it can be really embarrassing at times. People talk about their stomachs being really noisy during quiet meetings. They talk about not being able to control their bowels and having accidents. So the changes can be quite profound. I once worked with a woman who had a hemicolectomy, and she was going to the bathroom about 25 to 30 times a day, and she was on the sickness benefit, a lot of morphine, and on the FODMAP diet it went down to 4 times a day, so she was able to go back to work again. So this diet has really changed people's life quite a lot, right through to some people who just have a little bit of wind that they want to control. So the gas can slow the movement through the bowel, causing the constipation. People often talk about having trapped gas, really feeling like it's stuck in a cement in their stomach. So it causes all sorts of different symptoms, and that visceral hypersensitivity really makes them notice of these symptoms. They can almost feel the bowel motion moving around their digestive tract sometimes. So failing my lovely video, we've got this little diagram here where the wee FODMAPs, because they're not absorbed properly, they're still in the intestinal tract. They come down here where the bacteria produce the wind, and that luminal space is expanded. And that can be quite a nice little easy diagram. If any of you want it, I can send it to you, that you can just bring up on your computer if anyone finds that they've pushed for time. So how do we diagnose a FODMAP sensitivity? So there are two methods, and the first method, which used to be discussed a lot more, whereas not so much anymore, is hydrogen breath testing. Some places do methane breath testing, which, as you can tell, is important for people with constipation. So in Wellington, it's only Wakefield Hospital does it. It's about $300 per test. So for the lactose, the fructose, they also do sucrose. And the only time I ever recommend this is if someone's highly anxious or stressed, and I can't tell when the reintroductions, whether it's because the person's really anxious about eating that food again, or whether it's the fact that they actually are reacting. So if this is less and less indicated in practice these days. If somebody has health insurance, I might also say, look, it might just be worthwhile getting that diagnosis there as well. But there are definitely false positives, particularly with fructose. So what we do in clinic instead, and what you can do in your practice, is we remove the FODMAPs and then we do challenges. So it's a very structured, contained process that we go through, so that there's no room for anything else to be there. So if somebody's also cuts out caffeine and alcohol and sugar all at the same time, it gets very confusing about what actually is problematic. So we try to keep things one at a time. So humans don't actually have the ability to break down fructans and galactans, hence why they're so important for our gut bacteria. And we have limited ability to digest polyols, and they draw a lot of water in to be digested. So if FODMAPs are an issue, most people benefit from a reduction in those ones. The variable one is the fructose and the lactose. So if we're looking at studies, they show about 30 to 40% of people will have a positive breath test for fructose and with IBS, and with Crohn's disease it's as high as 60%. A lot of false positives there, but a lot of also reactions to fructose. So whether you react to fructans or galactans or not, again, depends on the types and amounts of bacteria that you have. So that's why some people can tolerate it completely fine, and in fact we encourage people to eat a lot of them. That's why we're encouraging whole grain breads and lots of onions and garlics and beans, legumes. Last year was the year of the legume because it's so important, 2017. So then we have with the fructose malabsorption, I kind of alluded to this before, but it's about how much fructose is in the food. So if we have an orange, as I mentioned, we have equal 50-50 fructose glucose. If we have an apple, we've got way too much fructose to glucose, but a glass of orange juice will just have too much fructose in one go. So even though it's got the right ratio, it's just a very high load. So a lot of people will get caught out by this, where thinking an orange is fine, so therefore orange juice must be. There are a lot of confusions when it comes to the FODMAP diet. For example, you're allowed oats up to half a cup, but you're not allowed any oat milk. You're allowed as much rice as you want, but you're only allowed 1 cup of rice milk. You're allowed as much rice as you like, but only 1 cup of rice milk. You're allowed to have as much polenta and corn chips as you like, but you're only allowed 1 corn thin. It's very confusing in terms of how the food's prepared, and therefore how it affects the FODMAP output. But luckily we have lots of lists and lots of diagrams to guide people through, but it's very hard for people to remember off the top of their head. If they go somewhere, if they're offered something, they have to almost get their app out, can I eat that? And it can be quite confusing. So how do people do it? So with the nutritional management, I've been speaking to GPs in Wellington about a reduced FODMAP diet. So what we do is we just reduce the apple and pear, we reduce the honey, the fructose, so we're looking for that on the ingredient list, high fructose corn syrup or fructose, the onion and garlic family. So when I mean onion family, do you know what foods I mean there? Yeah, the red onion, the leek, shallot, spring onion, those types of things. And then too much fruit, dried fruit, juice and wine, and particularly in children, you might find that they're drinking a lot of juice, a lot of fruit, having too much fruit and too much dried fruit. So when we see children in clinic, we might just look at what they're eating and just reduce how much apple juice or reduce how many pieces of fruit in one go they're having, so just to try and reduce the load, because we most certainly see this in children. And then we also look out for the artificial sweetener as well. So what we'll do is we'll do this, the GP will do this for 2 to 6 weeks, and if there's improvements, that's great. You just tell the person to just slowly reintroduce those foods back in again, just to see what upsets them. But if they don't improve, you might want to look at a referral to a dietitian to do things a little bit more condensed. I don't mind if lactose is reduced, because there's so many great lactose alternatives now. You have lactose-free milk, you have some centres around Wellington, you have around New Zealand, you have lactose-free yogurt, and you're allowed cheese, no problems with lactose, because it has the lactose removed during processing, as well as butter. So as I say, if the patient improves, that's fantastic, just encourage them to eat to tolerance. But if there's only partial or no improvements, we do refer to a dietitian, as we are encouraging that, because the complete low FODMAP diet does need a lot of education around what happens if you've got constipation, you're reducing all these fruits and vegetables and whole grains from your diet. How do you make sure your bowels keep working? How do you cope with going out? How do you cope with making sure you eat enough if you have a tendency to lose weight? What if you're sporty and you need lots of, you're used to having gels and used to having energy drinks and sports drinks that have got really lots of fructose in it? So there's often considerations that need to be made. There are some places on the internet that are really reliable, and so we give people some websites that they can use. And there might be other dietary factors involved. So when you reduce FODMAPs from the diet, as I say, you're reducing gluten from the diet. You're also reducing a little bit of fibre from the diet. So if someone has issues with insoluble fibre, you're also reducing that at the same time, so they might partially get better due to that. And you're also reducing some of the food chemicals from the diet, because berries some of the high FODMAP fruits and vegetables are also high in food chemicals, so we're having to just make sure that that person is getting better for the right reasons. So here's an example of I like to think of the FODMAP diet as swaps, to try and get it into someone's head that instead of this, we're just having that instead. So the great thing about FODMAPs is that they're water soluble, so if you have it in oil, the FODMAPs can't be released. So you can either cook some garlic in some oil and then just fish it out once the smell is released, or you can purchase garlic infused oil. Instead of onion, you can use the chives or green top of the spring onion or green top of the leek, which is usually thrown away but gives a lot of flavour and is allowed on this diet. Instead of cauliflower, we use broccoli. So we just talk about, what can we swap things for. When it comes to the bread, the really interesting thing is that if you get a sourdough bread that's fermented, what's happened is the lactobacilli that's in the fermentation helps to reduce the FODMAPs right down, so that actually a lot of traditional sourdoughs have less FODMAPs in them than gluten-free bread. So we're actually trying to get people to try and find these sourdoughs or make them at home if they have the time, but a default to that would be gluten-free bread. So that's really nice for people, because these it tastes much nicer, and it makes them feel like it's not so restrictive. There's also 2 other products available in the supermarket that have been deemed low FODMAP by the testing in Australia, and that's the Freya's lower carb bread. Have you come across that? Yeah, so it's right down the bottom of the bread shelf, but that's actually low FODMAP, so that's really normal bread, and what they've done is they've reduced the amount of carbohydrate and increased the amount of gluten in it, so it actually means that it's low FODMAP. And the other thing is, not that this are very filling, but do you know the sandwich thins? They're Tip Top make those sandwich thins that you pull apart. So they are also low FODMAP, and they're great as a snack or to fill up a meal. So it's really important to know those things that people can eat. We're very focused on what can you eat, what can you add back in again, what can you be eating to allow that to happen. So the reintroductions are vital. It's very specific, because if you try and use an apple to reintroduce, you're adding fructose and sorbitol back in at the same time. So what we do is we use honey, because honey only has fructose in it. And then we use an apricot, because that only has sorbitol in it. But we have to tell people they must only have one, because if they have 2 apricots, it then becomes a source of fructans. So you can see that we're very, very specific with the reintroductions, how much we have and how often we have it as well. I was actually talking to my table just before about how the wheat in Europe, the way it's grown, means that it has much less FODMAPs in it, and it's actually lower in gluten as well compared to the wheat in Australia, where a lot of our flour comes from. So you might get clients who go to France or other places in Europe and they can tolerate the bread much better over there, and that's because the FODMAP content is much lower. So I would get people try Italian pasta. So they might go to Italian food warehouse, or even in the supermarket you can get Italian pasta. So that's something I would try, particularly if the person's a wee bit nervous about gluten reintroduction. So that can be, sometimes I'll get somebody and they'll be gluten-free anyway, and we'll go, well, let's try the FODMAP diet, because I think that might be what you're more indicated for. And then when we're reintroducing the gluten, they're quite nervous at that point, so we might do 1 Vita wheat, or 1 water cracker, or 1/4 cup of Italian pasta, just to gain that confidence back up again.
Is that what's like sourdough bread as well?
Yeah, the sourdough bread, that I mentioned before, that's got the fermentation, which helps to lower. So the fermentation gobbles up the FODMAPs, because the FODMAPs are a storage component of the wheat. Yeah. And the final step is what we call established threshold, so eating to tolerance. So the person goes, okay, I react to these 2 groups. How much can I eat before I become symptomatic? So it's the key thing that we tell people is we want you to eat the most variety with the least symptoms. That's where we're trying to get to. So understanding the person's threshold is important, and just the key is to return to their usual diet with just avoiding those foods. So often we'll have people who can't cook with onion or garlic, but they can have it in their stock or in the jus or the marinade. So it's understanding those subtle differences that makes a massive difference to their ability to cook spontaneously. We have to get people to also understand which nutrients are lacking. So if they can't have some of the FODMAPs, their fibre might be lower, or their iron might be lower, or their folate or thiamine. So we just have to be careful that any extreme sensitivities are replaced with other nutrients. So just a few things to consider when we're removing FODMAPs. As I mentioned, we're also removing these other elements here. Therefore, we're just really careful. And as with any IBS study, there's always going to be a high placebo rate. I think it's about 30% of placebo when it comes to IBS. So we're always mindful that benefit stays true throughout the process. I have had a few people where they'll go out one night and drink wine and they'll get symptomatic, and then they'll remain symptomatic for weeks after that. And what we've realised is that the placebo effect was strong, and then they've gone out and just not paid attention to it, and then they've thought to themselves, I've ruined it now, and so therefore they've increased their symptoms due to the way that they've talked to themselves about the way that they're eating. So this is what the app looks like. It's a traffic light system, and it tells us what we can and can't have during the diagnostic stage. So if we click on one of these, the cherries, we'll see here that the red light is given to 6 cherries, but 3 cherries, it's got a yellow light, which means it's moderate. So any of the foods that have a red light to it, that's going to be for a certain portion size. And that's really important because some of these foods here are fine at a smaller amount. So if you were to see avocado has a red light next to it, but when you click on avocado, that's for half an avocado, which obviously at this moment, $6 an avocado, that's quite a lot. And then for quarter of an avocado, it's a green light. So there is an amount that you can actually have. So the difference between gluten and FODMAPs is quite a lot, but it's really important to describe to people when they think that they've got a gluten sensitivity. So the FODMAP is the carbohydrate component, the gluten is the protein component. When something says it's gluten-free, it doesn't mean it's low FODMAP. So people go, oh, I found this gluten-free cereal, but it's got honey in it, and it's got dried apricots in it, and things like that, and they can't eat it. Whereas on a gluten-free diet, when it says gluten-free, that means it's going to be fine. If a FODMAP product says that it contains gluten, it's fine if it's in small amounts. So it might have, starch thickener, or it might have a little bit of wheat flakes or things like that. So that's not a problem. Whereas it's not okay if you are celiac or strict gluten-free. So just a few examples here. Half a cup of pretzels, a slice of bread, half a cup of pasta. Those are all fine. They're all low FODMAP. If you had them all in one go, do you think that would be okay? No. So it's that threshold. It's that amount that you have in one go. So this is something I always show to people, is how we've got a red light next to bread, and that's because that's 2 slices. But if it's 1 slice, we've got a green light. So it's really important to teach people. If you have people in your clinic who say, oh, I've downloaded the app, I'm going to use this, just say, oh, look, just make sure that when you see the red light, it doesn't always mean you can't eat that food.
This is per day, is that?
No, per sitting.
Per sitting.
Yeah, per sitting. And the recommendations around fruit for fructose is you can have 1 serving of fruit at a time, and that's every 2 hours. So they're kind of thinking about it in terms of how fast it would go through the digestive tract.